Okay, do you remember where you left off? I think the slide's still up there. We're going to go ahead and press on, and again, there's going to be other members tapering on in here, so, but you're cleared to press on.
Thank you, Mr. Chairman. Moving on to the next slide, we've talked through this quite a bit already, so I won't go through in great detail, but as you can see, basically this just shows what are those 10 essential health benefits which the qualified health plans must provide, as you can see on the right side of the slide. And then also just to note that in addition to those in addition to those essential health benefits, there are also some Medicaid-specific benefits that we have to provide as part of the wraparound, and that includes non-emergency transportation and then dental and vision services for 19 and 20-year-olds.
Don, same sort of question as I asked earlier, would it be possible to get by each of those 10 services what the cost in claims data was for those items?
We can definitely work on that.
And I guess my understanding this morning was that if we did pursue a 1332, we could waive that so long as we had a comparable actuarial value package. Is that the way you understand it as well?
Yes, that's our understanding. It has to meet the same comprehensiveness and actuarial standards.
Okay, thank you.
Great. So digging then into some of the cost data, as you can see, this is for the first plan year for 2014. This is to compare traditional Medicaid, the top 6 cost categories for the medically frail. As you can see, this includes things such as inpatient, outpatient hospital, physician services, pharmacy or prescription drugs, in addition to mental health and dental. These 6 categories represent $110.2 million in spend, or approximately 88% of the overall 2014 cost for the medically frail. As you can see, there are some similarities to what we showed on slide 5 for the traditional Medicaid cost categories, things such as hospitals, physician and dental service.
Let me just go through this. On this slide right here, this 2014 medically frail, this is the 10% that we put in traditional Medicaid that weren't eligible for Medicaid before,
right?
Correct? And the cost was $102 million, which was 82% of their total cost.
110, yep, and 88%.
110. So they're also accounting for the total cost of the expansion program. We don't know exactly, but assuming it's 85% is what, 800 million or so?
When you say the total cost, so these folks are still covered at 100%.
Right. I guess what I'm saying is we're spending about $1 billion a year on the expansion population and premium support. And I was just talking with Director Seelig, the maximum that they have to spend at least 85% on claims.
Oh, right, for the medical loss ratio. Sorry.
Right. So we're talking about $850 million or so for those in traditional.
Right.
And if this had been included, it would have been an additional 12% or so.
Potentially, right.
Okay, thank you.
And so just to note, and I won't try to flip back and forth, but if you look at slide 5, which is where we had the cost categories for traditional Medicaid, you do see there are similarities between those high cost categories and those which we're seeing for the medically frail, particularly when you look at hospitals, physicians and dental services, pharmacy, and then for behavioral or mental health. The last slide really just shows you a full mapping of all of those categories of services for the medically frail over $1 million. So you'll see the 6 that were on the previous slide, but also others that are being utilized by the medically frail population. As you can see, the dollar amounts are obviously different for medically frail versus traditional Medicaid, but similarities exist across the types of services that these populations are utilizing, as we noted on slide 6. Just a couple examples that I would highlight in terms of comparing the expenditures between the two. Some are actually even higher in the medically frail population. For example, if you look at inpatient, outpatient hospitals, as you can see on the chart, it comprises about 32% of the medically frail costs. On the traditional Medicaid side, that's about 23%. So that's one example. Another one is physician services. For the medically frail, as you can see on the chart above, it's about 22% of the cost expenditures, whereas it's about 7% on the traditional Medicaid side. And the last one I would point out, just as a point of comparison, is pharmacy. I know that's one we talked about a little bit earlier, but for this population, for the medically frail, it's about 21% of the cost compared to 8% on the traditional Medicaid side. So definitely some similarities, but also some significant differences in terms of for this population, which we know may not have had access to services in the past before they came to us through the medically frail program. Yes.
Let me ask you one other question before you move on off of that. So again, this is people who are on the traditional Medicaid program, they spend about $125 million.
Mm-hmm.
And this would have been 10% of the population that is currently in the private option.
That's correct.
So about 25,000 people.
Right.
And I guess where I'm coming to it here, though, is while we would expect that they would be significantly more expensive because they're medically frail, like we talked about earlier, they're really equating to about 12.5% of what we're spending on the traditional population. So I guess what I'm saying is there's 10% of the population that has been removed.
Mm-hmm.
Had they been included, they would have added to another 12.5% to the cost.
Included in terms of in the qualified health plans, correct?
Right. So there's not as significant as a difference
right.
as you might think by pulling those people out of, or another way of saying it is the traditional population, the non-frail population is almost as expensive as the frail population.
Right.
Okay.
And that's definitely something, it's an excellent point that we're working on. As I mentioned, the Stevens Group is obviously very interested in the medically frail as well. And so some of the things that I know Representative Hammer and others asked about in terms of the per member per year costs, as well as Representative Ferguson, that's something that we're looking at now, and to make sure that we're basically comparing apples to apples when we do that. And so that's something we hope to have available for you either as part of a next meeting or just as part of some follow-up information that we'll be sharing along with the Stevens Group. So that's really all we had for today in terms of the medically frail versus traditional Medicaid. But obviously, we've written down several questions, things to look at in terms of more data and analysis, and we'll be happy to look into those. And once we have some of the information, we'll send along to the committee through Mr. Price, and certainly be happy to come back for a follow-up discussion.
Okay, Don, this is some great data as usual, and I appreciate the work you put into it, because I think this is, again, is the beginning pieces of information that we're going to need to start determining where savings are available, and particularly some of the things that you pointed out with regard to the difference in prescription, for instance, prescription medication on the medically frail population versus the traditional Medicaid program, but yet the overall cost isn't that far out of whack. So
right.
There's certainly some things that I hope our consultants can dig into this and give us some recommendations about how we can, where the problem areas are. Do we have questions from any members of the task force? And again, members, for your benefit, what we hope to do at the next meeting is have a presentation similar to this with regard to the cost. This is really dealing with the medically frail and the traditional Medicaid program. We'll have a similar presentation with those that are in the expansion population to determine what the costs are, what's out of line, and where the dollars are. So if there's nothing else, Don, thank you very much. Sorry you had to get interrupted there, but House did a pretty good job of getting their business done. So.
Appreciate the opportunity. Thank you, Mr. Chairman.
Thank you. Next item is item G. So Director Seelig, if you want to come down, and we're going to talk a little bit about Medicaid eligibility verification. So give us your name for the record, and you're recognized.
I'm John Seelig, Director of the Department of Human Services. Thank you, Mr. Chairman. I can see I'm a big draw. Yeah, I want to talk about the redetermination process because I know there have been questions about it and the delays that we've had, but I think it would be helpful to take about 10 minutes and explain kind of the underlying system, in part because the system that we have, this is one of our big eligibility, one of our big data systems, but because it's identified as a technical service by the Office of State Procurement, it's one of those initiatives, one of those sets of contracts that really doesn't come through the legislature for review, although we've talked about it many times at Public Health and elsewhere about how it's a real struggle to bring this system online. We have two big data systems. We've got lots of data systems in human services, but two big ones. One is our Medicaid Management Information System, the MMIS system, and that handles all the programmatic side of Medicaid and pays all the claims. The other side that we have that's Medicaid and other programs like SNAP is our eligibility and enrollment system, where literally for the million or so clients we have, we do most of the eligibility to see who qualifies for which programs and put them in the right place. We are replacing both of those systems now with enhanced federal funding. The Medicaid Management Information System replacement is going along well, kind of on budget, on time. That's a fairly mature market where there's a number of vendors who've been doing this for years. The rules haven't changed very much, so the replacement is pretty, I mean, you kind of know what the formula is for replacing it. The eligibility framework is quite different in that with the ACA, it brought in significant new rules for who's eligible for what programs. More specifically, it brought in the MAGI, the Modified Adjusted Gross Income, as the determiner of who's eligible for which programs that include the private option. Those new eligibility rules were something that our system, which is about 25 years old, couldn't handle, as was true with many states. And the federal government said, we'll give you 90% federal funding to help you replace your system so you can do the new requirements of the Affordable Care Act. And we took them up on that, as did a number of other states. But because it's new, because no one had done this magi before, it's really been a challenge for us. We took bids in 2012, picked a vendor. I mean, we actually put out an RFP, did bids, picked a vendor, and after months of negotiation, could not get that vendor to agree to some of the requirements we had, some of the penalties, et cetera. At that point, because it had been so long, the Office of State Procurement said, you can't really go to number 2 now, and there wasn't time to do a new bid because the requirement was that we had the new system stood up and able to accept new clients, including the private option clients, but also some existing Medicaid clients, by January 1 of 2014. So what we did was use an existing state contract that had a number of sub-vendors we could use. We basically contracted or had statements of work with those subs and managed the program ourselves, and we had one of those subs kind of act as the coordinating body. And frankly, that worked very well for us for the first 8 or 9 months, and we stood up in that amount of time what would normally take a year or two, probably closer to 2 years to stand up an eligibility system. As you recall, when healthcare.gov wasn't working and couldn't accept anybody, our system was up and working. We were accepting clients, and people were saying, look, skip healthcare.gov, go to Arkansas's Access Arkansas, and you can sign up for these programs because it's working. So that was a very big success in the first few months, but it took a lot of work. But that was really just putting in place the basic will get you eligible. It didn't do all the work we need in an eligibility enrollment system to shift clients from the old systems to the new ones, to when clients have a baby, or when they lose their job, or when there's a death. I mean, all the changes you have to make. We didn't have any of that functionality, didn't have the reporting. And a big piece we didn't have yet was that healthcare.gov was supposed to be able to send us electronic versions of who had applied there but is actually eligible for regular Medicaid or the private option. Our systems could just talk to each other, and same with us if somebody applied from us, but actually they were eligible for the exchange, because let's say they were at 200% of the poverty level, we could just automate it, send it back and forth. That component wasn't built, and the federal government began to tell us, well, actually, not only is it not built, we're not sure when we're going to have it. The rules kept changing, and it's just been a mess. So they would send us flat files, basically a sheet of paper or an Excel spreadsheet that said, here's 10,000 people who've applied from healthcare.gov. You need to process your eligibility. And we said, well, in Arkansas, you remember we're a partnership state where you determine eligibility and then we get them enrolled. But they just said we can't do it. So they were sending us thousands of people that we had to kind of manually figure out and rewrite software. Anyway, so it has been a huge challenge for us. And over the course of the last year, after we stood this system up, we had almost a year of, felt like almost paralysis. It was very hard to put the big changes in place that we needed. We got really bogged down, and our lead vendor just was not able to deliver, wasn't able to coordinate the work like we wanted, couldn't meet the time frames we needed. So we really had to take more and more of that responsibility ourselves with state employees. The federal government realized the same thing was happening in other states, and that's when the federal government said to the states, look, we'll give you delays on some of these, like doing redeterminations, because redeterminations was one of those components of this system that we simply had not built yet because we were dealing with all the mess from the federal government. And the new software we were using, the IBM software called Curum, was established for kind of traditional programs, but it also had never dealt with this MAGI requirements, and IBM was building that under federal guidance at the same time we were implementing it. So it's been a big challenge. That's all to say, in the fall of last year, we finally said, you know what, we've got to relook at this eligibility system because we were spending a lot more money, a lot more time. We initiated a really intensive review. In fact, I have weekly meetings with key staff where we looked at the vendors we were using. We looked at how we had done the procurement and whether we could change that. We looked at what was required to do versus what might be optional. Looked at costs, just kind of looked at everything across the board, looked at how we were managing it to see what we could do different. When the governor came on board, he quickly wanted to know how it was working. We've had a number of meetings with him, and because of his procurement background when he was at Homeland Security, he's gotten very involved and given us some kind of specific directions, for example, to say, look, just do what you have to do now. Other things I want you to put off and procure it through a bid rather than kind of time and materials, which is what we were doing through that we'd done initially through state procurement. We think we've got it back on track. In the last 6 months, we've made a lot of progress, including getting our redetermination process in place. But it is going to cost us much closer to what the federal government thought. They had said this system will probably cost states about $250 million, 90% is federal. Our initial estimate was that if things went well and the federal system worked like it would, we thought it would cost about $100 million. It's going to cost closer to the $200 million range, we think now, because of all these challenges we've had with the federal system. And it's just a big, complicated system. And that increase in the cost for the state means probably $8 to $12 million more in state funds. I was telling you, Mr. Chairman, the cost of these systems just kills me. I mean, spending $100 million or $200 million on a system. Then I think about the fact that even at that cost, even at $200 million over 2 or 3 years, that's the equivalent of about half of 1% of what we spend in Medicaid and SNAP. So if we have an eligibility system that really works, which this one eventually will, and helps us verify eligibility better and it's more streamlined, I mean, that's the gateway into ensuring we've got the right people on these programs, and it's a system we'll probably use for the next 20 years. So while it's a big cost, we've got to get it right, and frankly, part of the added expenditure is to get some more oversight, bring in some additional vendors to help us manage it better. Some of you all, if you've been on the Personnel Committee, you know DIS tried to get about 15 or 20 employees to help on this because we wanted the state to take over more, but they've not been able to hire anybody. You just can't find these engineers that you need. So it's been a big challenge. This system is going to cost us a lot more, but we are making progress, and we now do have the redetermination process in place. So with that background, I can answer a question on that, or I can tell you where we are on these redeterminations.
Have we redetermined anybody out of the program?
Well, so 2 things. We have had probably well over 10,000 people who have left the program since we started. I mean,
because we said you're not eligible anymore.
Yeah, I mean, in that case, that's primarily where they have given us information, or we've gotten information one way or another and determined, hey, your income is too high, or you now have private insurance. In some cases, they say I've moved out of state. We do a data match with vital records. If they're dead, we stop paying premiums. So total, it's well over 10,000 people.
Have we found people that we've paid premiums for that were dead?
Yes, and we recoup those. And that's going to happen. That happens in private insurance. You don't find out till after the fact that somebody died, and if you pay the premium on January 1st and they died January 20th, we may not find out till February or March through vital records that, you know, I guess the funeral homes submit that to vital records. We don't know they're dead until then, and then we recoup that.
But this new system, how much have we spent on it so far?
We have spent so far a little over $100 million, right around $100 million on it. And
all I'm saying is, has it produced a result that has removed anybody from the program yet?
So we are just starting. I think the short answer is probably no, because we are just now, well, actually it has. A number of those cases that we got from the federal government, in some cases they said we think they're eligible. We determined on thousands of them that there was not adequate information to determine that they're eligible, and we sent them notices saying, it appears you're not eligible, and we're going to cut you off unless you can provide us additional information.
But this is
so
initial
we use
enrollment.
The system for that.
But that's people enrolling initially, right? What I'm asking,
right.
Of the 250,000 plus that have enrolled into the expansion program or of the current Medicaid program, has this $100 million program removed one?
Probably, I can't say not one. Probably not. We are just starting the redeterminations now. We have done probably 10 or 11,000 redeterminations. I think most of those people were people who were eligible, but we will, as of probably about 2 weeks from now, we will start looking at about 3,000 to 5,000 cases per day to do redeterminations.
Who's the contractor for this $100 million program?
So there's a number of contractors. The lead contractor now is called E-Systems. Our lead contractor was EngagePoint. We fired them at the end of last year.
Is there a performance clause in this contract that says if we can't start removing people, you give us some money back?
We can't do that. The way the state procurement works on these state systems, it's this kind of mothership contract, and we're doing these subcontracts. We're not allowed by state procurement laws to put additional penalties in there. What we have done is tighten up our statement of work, where we've said, for example, E-Systems, this is what has to happen by June 30th. If it doesn't, we'll probably stop working with you.
What would be your estimate if right now that $100 million system were working perfectly, and it had been working perfectly for the last 6 months? How many less people would we be paying premiums for?
It's honestly hard to know, and here's why. We have tried to look.
Give me a range, 10,000 to
Well,
40,000.
So the estimates we got early on was that as many as 20 or 30% of the clients might have income increases that would knock them off the program. But when we've looked around the country, we're not seeing that. Very few states have done redetermination. So I just don't have any good data to tell you. I would say between 5 and 25%. I honestly don't know. It will depend on how many people, particularly talking about the private option, how many of those people have gotten good enough increases in their income to knock themselves off.
So at 5%, it's $5 million a month that every month that we do not remove those people, and at 25%, it's $25 million a month.
I think that's right.
I guess obviously you can tell from my questions that there's a lot of frustration because this is a very expensive buffoonery by whoever the contractor is to not get this thing working. And I hope that if there is some value in the task force model, it is to highlight efforts that need to be improved upon. And I know you're working on that, but I guess I'm to the point where I think maybe the contractors need to come explain to the task force why they can't deliver if we're spending that kind of money.
I think that'd be fine. I will tell you, some of these contracts, I think they're doing very good work. They and we have been very frustrated. The federal regulations kind of keep changing, and they'll say, well, we actually don't need this field to be 3 characters, it needs to be 6, and we need you to verify it this way, and we're sending you flat files instead of electronic. It has been a huge distraction for us and our vendors, because what will happen is, and I've had calls from you all, you'll call and you'll say, this woman applied 6 months ago, she's now going in for surgery tomorrow to get a new kidney, and she's still not on the program. And so we will have to take one of those programmers who's supposed to be writing the code and actually go in the system and fix it for Ms. Johnson so she can get coverage, because what the federal government gave us was bad data and she's hung up in the system. Or what happened was she applied at healthcare.gov, never even got an answer. So then she applied with us, or may have applied 3 or 4 times, and the system is just kind of locked up around her because she's got all these applications. So it has, the challenges from the federal government, and that's why I think they gave everybody delays, and now have said, we'll give you 90/10 money for 3 more years. They realize, so I'm not saying the vendors have done perfectly, but it's been tough for them and tough for our staff and DIS staff, because it is, it's like a moving target in terms of what we're supposed to be developing, and we keep getting pulled off on this other stuff.
All right, we got 2 or 3 others here. I got some others I'd like to ask, but Representative Farrar, you're recognized.
Thank you. Senator Henry asked most of my questions, but did we pay the vendor?
So yeah, these statements of work we have are for time and material. So we are hiring 20 systems engineers for this many hours at this rate. We're not actually, the way you have to do this through the state system is, they're not actually a deliverable where they're saying we will produce this product by a certain date. That's what we want to move to, and that's what the governor said. The parts that we can, that we don't have to keep doing now, let's actually put those out on bid so we can get a deliverable by a certain date. So an example of that is, we need to take the traditional Medicaid population and move them into this new system, but we're going to hold off on that and take a bid and say, you actually have to deliver that product by a certain price to get at what you're talking about.
Right, but the vendor that you hired to do this, we didn't pay him because he didn't deliver a product.
Well, but we did get the work. We got the 20 FTEs for 3 months out of them, and they worked. We eventually fired them because we said they're not. You're doing the work, but it's not good enough. And we are withholding money from IBM until their product works better. I think we're withholding over $1 million right now because their software is not working like it should, and they've got a team in here scrambling to figure out how to help us more because we're not satisfied with their work.
Another question. You said there was 5 to 25% that was probably not verifiable or shouldn't be on the system.
Yes, I think that's what we'll, in other words, as we do these re-verifications over the next 2 or 3 months, I think that's what we'll see, but we'll know better. Sorry to interrupt your question, but by the end of this month, we'll have a pretty good idea because we're going to start with those between 100 and 138 on the private option, verify them first because our suspicion is they're most likely to have had an income increase. They're kind of close already. So we should be able to give you a read in a month from now on how many of those people look like they've gone over.
Okay. Okay, and I guess here's the question. If we find that there's 20, 40,000 people on the system that shouldn't have been on there.
Right.
Does that matter? Do we have to pay the federal government back because they did not qualify?
No, sir. I mean, they've given us this waiver, this delay, so they will not charge us for the fact that it turns out they weren't eligible. And what happens is, we're looking at a point in time, we'll go look against state wage data and say, today, or whatever the most recent quarterly data is, if that's where we're getting our monthly data, it looks like you're not eligible. We don't know we won't be able to tell at what point their income changed or went up and down. We just say, as of our re-verification today, it looks like your income is over 138 or significantly different from what we have in the system. We send them a notice. They have 10 days to get back to us with verification. If they don't, we turn them off. Or if they get it back to us and it's not enough to verify, we turn them off.
But if we hadn't got this waiver, we would have had to pay the money back.
Yeah, I mean, if the feds had said, you don't have any extra time, well, I shouldn't say, I don't know that we'd have to pay it back, but we'd certainly be at more risk of it if they had not give us the extension.
How long, we got the extension, October 15?
To the end of September, I believe.
September.
Yes, sir.
October, okay. Thank you.
Senator Rayford, you're recognized.
Yes, and I apologize, I was held up for another meeting. Mr. Seelig, who oversaw this project? Who was responsible at DHS for this $100 million project that has given no results?
Well, no, we have results. It hasn't been as good as we want, and it's taken longer, but we've got results. The lead on it initially was our Director of Systems and Technology, who also has lots of other responsibility. One of the changes we've made is to identify a lead person.
How much was spent on the first contract where you fired the vendor?
Well, I don't know how much we paid to that vendor. I'd have to go back and
Is
find
there
it.
anybody in the room that can help you with that number?
Let me see if I've got it here. It looks like make sure I've got this right. Looks like we paid them $32 million to develop the initial part of the system.
Okay, you just advised me that you paid a vendor $32 million
Yes, sir.
and you fired him.
Yes, sir.
Who was responsible for hiring that vendor?
So
ultimately?
that was the team that we had that evaluated the project and then chose the vendors. It was us working with DIS.
Who was responsible for keeping them accountable before you spent $32 million of taxpayer money?
Well, they produced early on, as I said. They got the system set
Okay,
up.
I'm
So-
not speaking,
But
that's
so
the Queen's English.
So I'm ultimately responsible for using that vendor.
And I don't want you to take responsibility, it's not yours.
Well, it ultimately is, yes, sir.
I know that ultimately, but was there somebody on your team, in your executive team, that you were depending upon to monitor these results and make sure that we never got to a situation where we just spent $32 million and got nothing for it?
Well, so we did get something for it. We weren't satisfied with their performance, so that's why we let them go. But they created the system that allowed us to start eligibility.
And that system is not fully operational even now?
Not fully operational, no, sir. But we got work product out of them.
And you spent
It
now
just-
$100 million?
What's
That's
that?
what I
We
heard.
spent about $100 million on this project, yes, sir. Right. I mean, it has been a bear because of these changing requirements. It's been very difficult to get this done. I mean, we're now getting a lot more done. But like I said, this vendor who did good work in the first few months, as this project got more complicated, we were less and less satisfied with their performance, and so we have switched lead vendors, and we're not using them anymore. But we were paying for time and materials for them.
You know, when we talk about penalties and that's been managed, is there any penalties and whatnot? I just don't know how we could penalize the Arkansas taxpayers any more than we have. You know, and obviously I missed part of the meeting, and I don't want to plow ground that's already been plowed, but I can tell you that from the legislature side, we need some new leadership to help on this because it's very problematic. I don't understand how you've gotten to this point, spent $100 million on this project, and it's not fully operational. I believe that if I had been a part of that situation, I would be so embarrassed, I would say, we messed up, I'm sorry, and we'll move on. And that's why I would like to know who's responsible, because really, frankly, bottom line is somebody needs to be accountable for what's happening at DHS as it relates to this. And we've sat down here for this week in this special session, and we've grieved over $6 million a year in interest payments that we're going to make for a bond issue and things of this nature. We just don't have $100 million to be spending on something that doesn't work. With that, I'll stop. But I appreciate you at least trying to respond.
Well, yes, sir. And I mean, part of it is on us. That's why, and I don't know if you heard the part. I mean, part of what we looked at, and the governor asked us to look at, was how we were managing the project. And we have brought new leadership in on the project and put in additional controls, because we felt like as it got more complicated, we did not respond like we should. And I mean, I'll tell you, I'm sorry for that. I didn't get on it as quickly as I should have. And we didn't have the kind of, honestly, we were trying to, let me just say me, I was trying to manage this with our own staff as best we could, because I didn't want to spend a lot of money on additional vendors to manage this project. I think in hindsight that was probably wrong. I mean, and the federal government has said, and our consultants who we did the review said, you just need to hire some systems integrators, some project management office. You've got to have some additional outside expertise on a project this big and complicated. And I hesitated to do that because it's millions of dollars just to get that help. In hindsight, we should have hired them. So that's on me for, I was trying to save money, and I think I, saved a dime and spent $1. So that wasn't smart in hindsight.
Okay. Representative Ferguson. All right, push the, do you have either light on now?
Yeah. Oh,
There you go.
there we go. Okay. I had two questions, if that's okay. I talked to, let me see who I talked to. Wait, sorry. Delia Anderson, I think.
Yes.
She said you had a 1.6 upgrade to
Right.
the system.
Right.
I guess I thought that was going to fix it. Is it not fixed now? Is that not
So
the final?
that was one of the major, it was released 1.6 in these technical terms. And that did a number of the changes, including allowing us to do these redeterminations. So that was one of the major components we've put in, was 1.6. And when I said we've made progress since January, since the changes we've made, that was one of the examples of, I mean, it was a big watershed for us to get that 1.6 in, because it was a big system fix. But it doesn't do everything. For example, we still have the SNAP population, our food stamp population. We've got to integrate those cases into the Medicaid cases. So that's one of the improvements we've still got to make. We still want to make it easier for your constituents, our clients, to be able to go on the system and really be able to see where they are and what that looks like. But that's kind of additional software, additional coding you have to do to create. So there's these pieces we need to do. But that was one of the big ones, and that's why we're now able to ramp up and do these redeterminations that we had the delay on, is 1.6. Is part of what they did.
And that's only been in place for 2 weeks, right? I thought.
Yeah,
Weekend
about
before
2 weeks ago.
last or
That's right.
something like that. So
Right.
it's very recent.
Right.
But that's not the final fix, is what you're saying. These other things will have to be done yet.
That's right.
I guess my concern is, are you going to be able to provide accurate data to Stephen to do their eligibility verifications? I mean, how much of it is still on paper? How much is actually in a file you can download for them?
So we think we'll be able to. A significant part of the Medicaid program did not go to these MAGI rules, and it's actually the expensive people, the long-term care, the aged, blind, disabled, the kids who are on the TEFRA program. Those folks we have continued to do redeterminations on all along. We've done about 60,000 of those just this calendar year. So, and that total population is probably 150, 175,000 people. So, for example, the Stevens Group could start with those. Those are up to date. Then we will, as I said, we'll be doing 3,000 to 5,000 people a night by 2 weeks from now as we ramp up. So I think as we do, for example, the 100 and 138 population in the private option, the Stevens Group can probably come right behind us and do their work. And if you look at the Stevens work plan, that eligibility scrub, at least from my look, it looks like it starts in mid-July, so there's actually some time here for us to even get further down the road. So I think it'll work. I can't say it'll be perfect, but I sat down with John Stevens, with both of our staff, and that's part of what they mentioned. Acuity and LexisNexis, they're actually meeting with our staff today to figure out the best time frame to do that.
Okay, thank you.
Okay, Representative Hammer, you recognize.
Thank you, Mr. Chair. John, who was the head of the team that headed up the decision to do all this?
Well, Dick White is our lead. He runs our Office of System and Technology. And then we have a team that includes senior people from Department of Information Systems who've worked with us.
Okay.
We have kind of a governance team that has overseen this project.
Now, I'm talking about the one that goes back to the decision to utilize this program.
Right. You mean to replace the old system or to take the approach we did?
To Senator Rapert's question, when he was asking who was responsible,
Right.
would you provide
What's
us
up?
with a list of the team that helped to make the decision and who headed up the team?
Sure.
Okay. And then, was there, in all the dollars that were being thrown around, the 100 million and all that, is any portion of that have a state match requirement to it, or was that all federal dollars?
No, the state match requirement, it works out to about 12.5%.
Okay, so
Is the state's share of that. So our total cost at our current, if this ends up costing $200 million, our total cost will be about $25 million for the state.
okay, and that's reflected in DHS's budget, is that right?
Yeah, that would come out of almost exclusively out of our Medicaid administrative budget.
Okay. And then that contract, how was it originally issued and under what authority? Did it come by us as legislative body? I don't remember that.
No, sir, it's a, we initially, and I don't know if you're with this part, I don't want to repeat myself, but we initially put out an RFP for bid and had a number of bidders, selected a vendor, and we did that through the Office of State Procurement, selected a vendor and negotiated with that vendor. They're called Noridian for months and could never get them to agree to the contract terms. And at that point, the Office of State Procurement said either it's too late or for other reasons, we couldn't go to kind of whoever was number 2 in the scoring. And so at that point, we used, the state has, and this way, I don't know what the term is, but state has kind of standing contracts for IT vendors. And we used that standing contract to hire some of the same people that Noridian would have used had Noridian signed the contract. So we did individual statements of work under that mother contract, that global contract. We did statements of work with individual vendors for certain amounts of their time and effort for different parts of the project. But it did not come here. That was considered by Office of State Procurement, that kind of work, not just this contract, but lots of it like it, as technical services work and technical services contracts until a few months ago. My understanding is it just didn't come to the legislature for review. I think they were seen more as kind of commodities that didn't come to the legislature. I don't know whether that was a legislative decision not to review them at a certain point or state procurement, but for whatever reason, that doesn't come here for review. It does now, but it didn't, I think, until probably January.
Okay, one last question. Was there, do you remember anywhere in the contract, was there any sort of performance review that it got to a certain point and it was supposed to be reviewed, and if it wasn't doing its job by that point, then it would be cut off sooner than later? Do you remember any of that, or we'll get the details on that?
No, so I think it's more, in these statements of work, you're basically purchasing, for lack of a better term, time and materials.
Okay.
You're purchasing this many people at this skill level for this long, and you say, I want them working on these things, but you can't, for example, put a penalty in if they can't get done. The state procurement rules don't allow you to put in penalties on top of whatever's in that broader contract. That's what we have tightened up, those statements of work, where we've made it more clear to your point. Look, we expect this to get done. If it doesn't, we're probably going to use somebody else.
Okay. Thank you. Thank you, Mr. Chair.
Representative Gray, you're recognized.
Oh, there we go. Thank you, Mr. Chair. Kind of a statement first and then a question. You keep reiterating that you have gotten results out of this contract. I would like to say that if I go to Walmart and buy a television, I pay $1,000 for it. technically I have results because I have the TV in hand, but if it doesn't work, it's no good. In my opinion, results are the actual verification of people, not the product you have in hand, because it does not work. That's just my take on that. Also, you know, it's 12.5% match that we're putting out there. We're struggling right now. We cut $1 million to our senior centers, to our libraries, and we're spending 12.5% on something that we don't even have results for. So us as legislators, especially me as a freshman legislator, it's very, very frustrating to hear this. It's disappointing. And I guess where I'm getting with this, one question that was asked earlier was, who are the actual subcontractors? Did I miss your actual answer, or did you not ever actually tell us who all the subcontractors were that were included in this $100 million?
There are a number of them.
Would you please let us know who they are?
Sure. Engage Point was one of them. They were the lead, and that's who we stopped to work with at the end of this last year. There's E-Systems, Redmayne, CAI, IBM. IBM actually provides the software, kind of the software product behind it. I think those are the primary ones, but if there are others, I'll provide that too.
All right, thank you. Do any of those subcontractors have any other contracts with the state of Arkansas?
I don't, actually, I'm sure that they do, but I couldn't tell you what they are.
Okay, thank you.
Because they're subcontractors. When I talked about that big contract that the state has, they are subs under that big contract, so my assumption is they do work elsewhere in the state.
Okay, thank you.
Okay, members, we're going to start some repeat questions now for members, so try to keep it short because we've still got another item on the agenda. But Senator Rapert, you're recognized.
Thank you. John, I've been sitting here thinking about your answers to my questions. Are you understating the cost? Was not the first contract $60 million?
When Noridian put their bid in for their piece of it, that's a contract we could never finish with them. They bid about $60 million. But our estimate of the total cost was about $100 million. Because there's effort from the state, there's all kinds of...
Okay, let's play simple.
Okay.
Did you pay out $60 million or $32 million?
The $32 million was to Engage Point.
Okay.
Different than Noridian, because Noridian never ultimately agreed to the contract.
But did they get paid too?
No.
Okay. So where's the $60 million? I think there's a spreadsheet of some kind.
So the $60 million was the bid from the vendor that we did not use.
Okay.
Okay. The $100 million is the total cost that we have paid out to various vendors and spent on space and state time. And I mean, there's other maintenance, DIS costs, some of those.
We spent $100 million or $130 million?
We have spent $100 million. Our estimate of work through the end of the federal fiscal year, which is the end of September, is about $130 million. That may be where that number comes from.
All right, and again, I've been thinking about your answer. I like Representative's answer, and I can't even see her name down there. I apologize. Representative Gray. I need to come to the House a little more often. What did we get for $32 million?
So what we got?
No, I'm serious. I mean,
Yes,
help
sir.
me. I'm trying to be very honest here.
Right.
I want you to tell me, do we have something that fits in a shoebox? Or do we have something that fits in a truck?
Yes,
What
sir.
did you get for $32 million?
So here's what we got. Again, it wasn't just that company. There were a number of vendors working on this, so I can't tie this exact, but they were the lead vendor. You know, healthcare.gov at the federal level was where, through the ACA, people were supposed to be able to sign up for healthcare.
And that, yeah, I had a lot of problems.
And it didn't work, right?
Yeah.
We built that our version of that here, and it worked, and we got that on time.
Okay.
So that, and the basics, that worked, and we got it.
And that was part of that $32 million?
Yes, sir.
Okay.
What we didn't get was all the other enhancements and functionality, like being able to do redeterminations, like being able to talk to the federal system automatically. Those pieces did not work, and as we continue, ultimately, that's why we got rid of that vendor, because they couldn't seem to produce that. They weren't providing the leadership and coordination to get it done.
So all that we got out of that is a website, right?
Well, it's more than that. I mean, I'm
Do
not a
they-
technical person, but there's a whole lot of software and coding that goes behind that
Sure.
in order to get people enrolled.
But in terms of that, that was not them providing any personnel that's answering phones or doing anything. It's just running that website.
It's building the system.
Okay. $32 million. And that was paid to them over how many months? Just estimate. I don't
Yes,
want to, I'm not going to hold you to
I'm going to
say
guess a year and a half.
year and a half.
Yes,
It's
sir.
a pretty good gig.
Yeah, it's outrageous what we have to pay for this.
I'm very frustrated. I'm frustrated more now. I'm frustrated more today than I've been in a long time. Because for the life of me, we sit here and we ask questions, and it is very frustrating. And we've spent more on you trying to figure out a way to figure out who shouldn't be on this system than probably the total sum of what we're going to gain by kicking them off the system. So it's very frustrating, Mr. Chairman. I'll be done completely with this. I think that perhaps this matter will be delved into a little further at another meeting coming up. But here's the thing. I'm going to give you a hint. It'd be better off for you to just tell us who was responsible for this mess and get rid of them, rather than us have to come over here and completely can continue to ask you questions and ask you questions. The bottom line is we got a problem. There's been $100 some odd million spent. It's not worked properly. And you know what? Somebody should be responsible for that. Nobody else gets to get by with that in business. We need to raise the bar a little bit here. That's my opinion.
All right.
Thank you.
All right, members, and again, my understanding is, and I think you testified to this earlier, Director Seelig, that now, because of the new constitutional amendment, these type of contracts will come before the legislature for review. We're not going to turn this into a contract review committee. Those kind of details do need to be reviewed and thoroughly vetted by the legislature, and maybe we can prevent some of this in the future and correct things that screw up in the past. But so we've got a couple other on the list here. I would really prefer that we get back on the topic, which is, are we now comfortable that we are going to verify those that are on the program and remove those that are not? So I've got a couple questions about that. And again, we all understand I think we've pretty well made it clear that there's a lot of dissatisfaction with how we got here. So what I want to know is, moving forward, do we feel like we're on a path now to be able to be confident that we're going to clean the roll up?
Yes, sir.
Okay. Representative Ferrari, you've got a question?
Well, I think so. I think you just stopped me from asking my question, but I'm going to ask, what's it going to cost to maintain the system when it does start working?
I'll have to ask. I don't have that in front of me.
Okay, we don't have any clue.
No, sir, and part of that will be, I mean, we'll shut down the old system, so it'll be the difference. And I do want to just point out, Mr. Chairman, again, I don't want to say that people could have done better jobs in lots of places. The primary cause of this has been the difficulty with the federal government and the changing rules and the fact that the federal website didn't work. It has created havoc for our staff. We've got some staff who've been working kind of nonstop on this. It's been very frustrating for them, and it's been frustrating for the vendors. Again, I don't want to say people are blameless. We could have managed the project better, but the primary reason for these cost overruns is because we've had to deal with changing requirements from the federal government that has made the software not work like we expected, and just pulled people off of this project that we needed working on the improvements.
Okay. You done, Representative Furr? Yeah. Representative Hammer, you recognize?
Thank you, Mr. Chair. Maybe if the chair wants to hold off, if we're going to have Mr. Stevens come forward, what I'm interested in knowing is if we're going to continue to put money into what we've got, and we're not certain what the cost is going forward, and I think it's part of Mr. Stevens' RFP that we're going to have some Medicaid scrubbing, and for the price that he is covering it for, I'd be interested to hear a joint discussion as to why one is necessary to move forward with the other, and just how those two are going to harmonize so we aren't spending money twice.
Mr. Stevens, would you mind coming forward? And I think what we need to know is, are you comfortable that you can give us your scrubbing process will be valid because of the transition period that we're in? you know, I guess what and I think it's a valid point, is there's no point, I mean, if we're going to scrub the rolls right as we're implementing a system to scrub the rolls, is there any merit? Is the timing right? Are you comfortable that we're going to get real usable data?
Well, part of our team is meeting with the director's team today. I've heard a lot, and we've been working together. So I want to be able to go back to the team and ask them what their thoughts are after the meeting today. I feel that, you know, we could accommodate the, you know, the ones, at least the long-term care, and some of the ones that are already in the system that are not going through the issues right now with redetermination. Maybe we could segregate those off. But again, I'm not, the experts on my team are meeting with his team right now. I'd like to be able to talk to them. And I also want this committee to know that we also have, I have someone on my team who is also very knowledgeable on procurement rules in states, contracting, IT, actually is the bridge for the secretary in Florida for any type of change orders on large IT contracts. She's been meeting all day with the department staff and will continue to. So we're going to be able to also update you on some of the things we're seeing, which is part of our RFP scope, to look at the department's contracting practices and procedures as well.
May I, Mr. Chair?
One more.
What I'm having a hard time getting my mind around is that we're spending multi-million dollars over on this side, and I understand about the federal government change, and I can identify with that. Makes me want to go back and ask them for our $25 million back, honestly. But then, you know, we hear you on this side over here, and that's a big price disparity. So I'm wondering, you know, did we pay somebody to invent something new, reinvent the wheel, or was there something else that was out there that we could have gotten for less money and done just as effective of a job if you're going to be able to come in and do what sounds like basically close to the same thing? And so I'm trying to draw a parallel.
Sure.
What's the differences?
Well, I want to make sure your expectations are met. I mean, we weren't hired to fix the system. We're only hired to look at the data and to tell you, when we scrub that data, if we've identified that there are problems in the way what we're seeing in the results, that these determinations, eligibility, the first run too, whether or not they overlooked a residency issue. Maybe they didn't look at an asset issue. And we're finding that there are some glaring issues here. The benefit of having our team also working and knowing what the commissioner or the director's doing and his team now is, our goal is to provide you with, to make sure as an independent voice, what we think the solution could be going forward. Whether it's working, whether it's going to be consistent with some of the practices nationally, and whether we think you've absolutely filled those gaps and holes, so you're not going to have representative major problems going forward. But we're not being asked to fix the system.
Question of the chair. What I'd like to know is, between now and October, when it comes out, how much more are we going to spend on the contract that DHS is involved? And would there be any reason or justification to put a pause to that, if we could, while we wait for the Stevens recommendation? Because we may be spending money that we're going to find out in this process wasn't good money to keep spending, if that's a fair question to ask.
Well, I'm not the one making those decisions, but I guess I would ask you, Director Seelig, do we anticipate additional contracts or additional costs as you roll forward in the implementation of this between now and October?
We don't anticipate adding anything beyond what we've already committed to, and that's one of the things the governor had us go through, working with Department of Information Systems and others, is what is the stuff that has to be done to meet federal requirements, and he's already had us stop anything else until we can see. And in fact, he said part of what he wanted to do was see where the task force ended up. He said, because if we go with a different type of program, it may turn out that what we're building for the private option we don't need. So he's asked us to put any of that work on hold and just do what we need to do this year.
To meet your deadline for verification and so on.
Right, that's one of the examples, that's right.
Okay. So to summarize, when do you, time frame on actual operational success?
Right. So we should be able to, by this time next month, come back to you on that 100 to 138% population and give you a pretty good read for how many of those people we're knocking off. We won't ultimately know how many we will, because some of them will still be in that 10-day period of being able to give us information back. And people can, if they don't give it back to us, they could potentially reapply. But we'll be able to come back to you and say, of the first 50,000 people or 30,000, whatever it is, 10%, 15%, 6%, we sent letters to saying your income doesn't look like it's what we have. You need to give us information. And we'll be able to tell you of those who passed the 10-day period, how many of them even got back to us. Because if they didn't get back to us, we'll cut them off the program. So we'll have some real numbers for you about what we're seeing, at least with that higher income population. Then we'll work our way down the private option from there.
We'll keep that as an agenda item for a
Okay.
monthly status report on how this process is going. We've got one more question here before you take off. Representative Ferguson.
Hello? Oh, thank you. And this was my question to the chairman last week. And maybe it's a better question for Representative Meeks and some of the people that were the most interested in the scrubbing. My concern is if Stephen does the scrub now with data that we know is inaccurate and hasn't been worked because the system has only been up for a couple of weeks. I mean, I don't want us to spend all that money for him to do a scrub and then the answer be, oh, well, that was done and now things are better. So I guess my question to the committee would be, is that portion of the contract, the scrub, is that something that we would want to extend the contract for a month or two because it's not really pertinent to the overall innovation plan of what we're doing, to make sure that we don't think we need to do another scrub because we would have done it with inaccurate data. Maybe as Representative Meeks here.
Yeah, it's a good question, and Representative Ferguson brought it up, is we don't want to get a list that says, and the answer is, yeah, we already fixed that. So I guess I'd ask both of you two to comment on that. Is there value in delaying for 30 days or 45 days the beginning of that scrub process and the pulling of that data until you've had a chance to begin this verification process?
Yeah, I think it's a really good question. I think that the delay is one I want to talk to the team and figure out what it's going to do for in terms of our October 1 time period. Remember, they're going to take all the data, the beneficiaries, all of them, and they're going to put them into a database that's going to begin to look at these national databases that the director is not going to have access to anyways. He doesn't today. His systems are not that sophisticated. So you're going to get additional information anyways. The only issue from my standpoint is the timeline. If we were to wait, is that going to impact? Because it takes a number of weeks to do that scrub in that national database that the LexisNexis folks have. And will that delay us on the October 1?
I guess what we're talking about is if the task force decides to waive that requirement for this particular result, would that have value? So why don't you talk to your team and talk to the director and come back with a recommendation for it? You're not going to be past the point of a decision prior to the June meeting?
No.
So that'll be an agenda item as well as the timing for the scrub to make sure it has value.
Yeah, and the only thing I would say, though, is so that I understand if it's okay, I think we still need to work forward on laying the groundwork with the data fields and the attorney contract agreements, the BAA. These are some national, not just HIPAA. There's credit reporting acts. There's all kinds of contractual. And I wanted my team to work with their lawyers to get everything ready. And if we could just continue to move forward there, that would help.
Would that work?
Yeah, and I guess that was my question. I just want to make sure that we're getting the most bang for the buck and what we're paying for, since the system that they're saying is better has only been in place for a couple of weeks. And if extending that portion of the contract would facilitate that.
And it could very well, next meeting we'll be able to, at least, I think we'd be able to give you a...
Yeah, I mean, the other possibility perhaps is, I mean, my sense of the scrub is, it will tell us, are there additional things we need to be doing, new components, new vendors, to on an ongoing basis, verify whether people are eligible and get them off the rolls if they're not? It may be that there's, even if they don't do everybody, that they do a big enough sample. I mean, if they look at the 150,000 aging, blind, disabled others and say, hey, just based on that, we can tell you need to do this or that, it may still be of value. The committee may want to wait and do everybody, but I could see some value. Or if they look at a third of the private option population and say, even looking at a third of them, even looking at 75,000 people, we can tell you these things, there may still be some value there. But again, I think our staff should talk and.
And I guess my other question for Mr. Stephen would be, am I correct in that this sort of scrubbing part of the RFP contract is completely sort of separate from everything else? I mean, what you're doing with the scrub is really separate and doesn't affect the rest of the plan for innovation.
Absolutely.
They're not tied together necessarily.
No, but the scrubbing, what's going to be really good is it's going to actually reinforce maybe what our thinking is in terms of giving you some solutions going forward. And the other thing is the contract. I'm really excited for all of you because I know this discussion is a tough discussion. I've been a commissioner. I've been sitting in committee hearings like this. There are IT contracts very difficult in states, but you got to get a handle on them, and the director knows that. But I have people on my team that I feel are national experts on contract procurement issues, especially with IT. So I'm going to be able to give you, and I'm hoping at the next meeting, a good read on what we think potentially needs to happen or work with the director and his staff, but also answer some of your questions independently, Representative.
I will leave it to y'all's opinion. I mean, it's certainly, I think, up to you all.
Okay, thank you, Mr. Young. And what goes through a lot of our minds, I know, is, okay, well, you testified, Mr. Stephen did, that the scrub he can do for $100,000 or 10% of the $1 million contract price, and we're going, well, why are we spending $100 million? We could scrub it every month for 100 years and come out, ahead. So that's where a lot of us are struggling with the incredible IT costs to develop a system that is apparently not that difficult to scrub.
But so I think the big difference is the scrub. He will take the data that we have and run it through, almost like Axiom does, run it through some systems and see if it looks like it's accurate. That's very different than the process of actually making someone eligible, being able to change their situation, seeing if they're eligible for, it's the actual processing of the application is very different than taking the data and, the comparable for us would be when we do these redeterminations, we'll bounce the data we have off of workforce services data. That's a very simple process once you've got it built. So it won't be expensive for us to bounce that data. The redeterminations themselves are not expensive.
Right.
What's expensive is building the system that underlies it.
Okay. Director Seelig, thanks for your testimony, and as I said, we'll get monthly updates and see how this new system is working, and hopefully we'll get some good news.
Good.
Thank you all. We got item H left. Billy Tarpley of the Arkansas Dental Association, are you still with us? I hope you weren't expecting to testify at 10 o'clock this morning. We kind of had a long day, but we appreciate your patience in coming down. We're going to have a little bit of review of Medicaid and how it affects dental operations. So just give us your name for the record, and you are recognized to give us your report.
Thank you, Mr. Chairman. Thank you, Mr. Chairman. Members of the committee, I'm Billy Tarpley. I'm the Executive Director of the Arkansas State Dental Association. And number one, thank you for what you're doing. It's so important. And it's so critical. I appreciate the governor's heart in making this happen and the spirit behind it. Appreciate your efforts and your involvement. And this is the first task force meeting I've attended, and you have a difficult task before you, but thank you for doing it. And I will be brief. I understand the time of the day, and mainly what I wanted to do was to come and visit with you to reassure you as the task force that the dental community within the state is very, very engaged in Medicaid. And we have been, I think Dawn is my 5th Medicaid director that I've worked with, going all the way back to Ray Handley. So we've been at this for a while, and dentists are very much engaged in it, very concerned about where we're going with Medicaid. I think as much as anything is for you to understand and maybe to gain some knowledge about what it is that that we do within Medicaid. Our group as dentists have always been willing to not only identify a problem, but to try to bring a solution to it as well, and that goes back decades. And we're trying to do that as well again. We work very closely with DMS and the staff over there, and God love him, Ward Hanna is sitting here in the room, and Ward has just done an extremely good job trying to work within dental. But here's the biggest problem that we have. Dental is always going to be anywhere between 2.5% to 4% of overall Medicaid expenditures. But the staff is challenged with trying to manage a dental program underneath a medical model, and those just don't fit. The delivery services are different. Dental is its own animal. When you think of it, a patient arrives at the doctor's office, goes into, when Dr. Ferguson was practicing, a patient would present to her office. Dr. Ferguson does the diagnostics. She does the treatment, she does the dismissal, and she has a staff there. So she's more or less operating her own little hospital and surgery room. So that's a different delivery model, all within one area, than it is in most of the services that Medicaid pays for. I was interested in the information that Dawn presented earlier about the medically frail population. Even within that group of new people who came on to Medicaid, and these are people who most certainly did not have a dental home. Before that, the dental expenditure was still 4%. It's just where dentistry fits within the hierarchy of costs that Medicaid is going to come up with. So having said that, I wanted to bring to you some of the Dental Association's concerns and a request that perhaps part of your report would include taking dental and the administration of the dental program and trimming it away from the challenges that DHS and DMS have, and give it to a third-party administrator, a third-party contractor, even on a pilot basis would be helpful. We within the dental community understand the differences that go along with running a dental program, and we believe that the dentists overseeing a program would be able to deliver the efficiencies that we're all looking for, would be able to help with the costs that are involved in it, would help deliver more care to more people over a period of time. And as I say, even if you did it on a 3-year pilot program, we just feel confident that we could take away that challenge and that burden from DMS, give it to a third party, and at the end of 3 years, I just believe we could show you some efficiencies.
Sir, would you be something like saying, you know, today we're spending X million, so we're going to give you X million minus 20%. Make it happen?
Well, dental is about $130 million, I think, for the last completed fiscal year, and I believe what we could do is to take that program and find certain efficiencies separate and apart from the administrative burden of DMS, deliver the care faster and make it more feasible.
I guess one of the we're going to get lots of requests for these different kinds of things, and I'm interested in pursuing them and understanding them.
Yes, sir.
But what's going to happen, in my view, is we're either going to micromanage you, as you observe that we're good at doing, right, or we're going to do for you what we're asking the feds to do for us, which is stop micromanaging us. Give us the doggone money, tell us how much you need to save, give us what's left, and let us figure it out. So I've got a lot of energy for someone that's willing to say, you know, hey, give me X minus 20%, X minus 30%, and I'll deliver a solution, and then I don't need to micromanage who you do it with or how you do it, because I'm spending a lot less than I was before. I get my savings up front, sure, and then you figure it out. Sure. But what I'm very skeptical of is just saying, hey, this one doesn't do it very well, I'm sure we can do it better, because I don't understand on the front end how that's going to work. I don't doubt that you might be able to, but if you can, I get excited if somebody says, give me 80% of the money and I'll make it happen. Does that make sense? Is something like that possible?
Yes, sir, it totally is, and it would take a little while to develop that number. Would be more than happy to bring that back in another document or another presentation if that would be helpful. We'd be happy to do that.
Okay, you have more, because we got a question, but we can wait till the end if you want to go ahead. Or
well, Mr. Chairman, I think that's pretty much it. I also wanted to point out, and on the second page of your report is
members, that handout is in Exhibit H of your packet there. If you want to see what it's in your notebook under today's date, Exhibit H. And Representative Hammer, you have a question?
Yes, sir.
Thank you, Mr. Chair. Don't take offense by this term. I'm just trying to get my mind around this. Is what you're proposing the dentist version of managed care?
Well, the dentist, of course, like the fee-for-service program, because it allows the doctor to take care of the patient as they see fit. We would, under what we would recommend would be preservation of the fee-for-service program, because that allows the doctor to take care of each patient individually. Obviously, with Medicaid, even with Medicaid, you only have 50% utilization. So when a patient actually presents to the doctor, generally it's because they're in pain. Certainly you want it because they've achieved good oral health and they want to maintain that. Generally, though, it's because that patient is in pain. And pain, the causes of pain are different with different patients. And so we certainly would hope to preserve the fee-for-service model versus a managed care model that assumes all is the same.
If I just have one, what would be your method of going out and identifying the individuals? Would you count, and you know, you heard all the discussion previously, so you would work in conjunction, I guess, with, you know, with the other aspect of Medicaid to identify who the people are in order to go out and basically just monitor and get them in the system to help keep the cost down, or how would you do that?
Yes, sir. To our way of thinking, the patients would come just simply through eligibility enrollment the same way as they do now. And the patients would still seek dental care the same way that they do now. What would be different is that under our plan, we would manage the network, we would manage the claims adjudication and administration of those things to take away some of the burden from DMS staff trying to manage it within a different model. So we believe in having a dental-specific third-party administrator. We would be able to find some of those efficiencies that we know are there, and utilizing the technologies that we know are there. It would just be different from what the state is utilizing right now. But the results of the analysis, the independent analysis that begin on page 2, are actually aimed primarily at keeping the system that we have right now. The consultant who did this work for us recommended outsourcing administration to a third party, but he said if that's not done, he had made recommendations for the existing program and how it could be improved.
All right. Thank you, Mr. Chair.
Representative Ferguson, you're recognized for a question.
I can make it a question, but it's more a statement. I don't think maybe the committee understands that the Dental Society independently paid $30,000 for a consultant to look at you might explain that, to look at the dental program, because particularly with electronic filing and getting predeterminations for surgical extractions and all of those kind of issues in a dental office, the existing Medicaid program is very inefficient. And we felt like it was important enough to look at Medicaid payments. This is just a summary. There's a 30-page consultant report if people would like to read exact things. But you might talk a little bit about why we chose to spend the Dental Association money for a consultant and the deficiencies in the Medicaid program and why it's frustrating for dentists.
Sure, happy to do that. And the Dental Association has a sole source contract with the state to provide Medicaid consultants. And so we actually do that and provide the doctors who review the claims. As part of that, we get information that comes back about the program itself, and we try to deal with Ward and his staff on the frustrations that they have. But there was enough consensus of concern that we wanted to have an independent consultant come in to take a look at it, someone who's knowledgeable in this industry, knowledgeable about what's involved, and that's why we chose Mr. Oscar Bryant with Immersion LLC. And Oscar came in, he's from Virginia, came in and did a great job of summarizing it all for us, but even the 30-page report that we have is only a limited analysis of what's going on. What he tried to do is to come in and say, let's take a look at where the real problem areas are. That's on the claims adjudication side and the payment side, and see what can be changed. And certainly that was, I believe that's money well spent. We got a great product, and he's even still willing to come back and for free consult with the state to help implement some of these changes. DHS staff embraced some of these, but I think over time and over administrative burden, some of them just haven't been done. But some of the recommendations are incredibly simple, and that's to try to steer away from paper claims. John called them flat claims earlier. Try to steer away from paper claims and go to electronic claims. Electronic claims obviously are much simpler. They're more efficient. Not only from the electronic claims submission side, but from the X-ray submission, the claims review process, and the payment. The more electronic it can be done, the more efficient it can be done as well. But certainly someone like Mr. Bryant has the knowledge to help make recommendations that we would find to be helpful.
Okay, Senator Rice, you have a question? You're recognized.
Hey, Mr. Chair. Mr. Tarpley, just I'm looking on the thing, and I point out for any members that hadn't noticed the 400 to 700,000 fraud, waste, abuse on there, and having dealt in one of those cases and tried to get DHS to look at it, they said, "We'll just pay it." And I said, "No, I don't want you to just pay it. There's a problem with someone that filed and you paid. The work wasn't done. Well, we'll pay it." You know, went through that back and forth. What kind of time period on implementing a program like this are you talking about from the consultant that you had switching over for efficiency? Do you think it would take?
I think a lot of it would depend on the current contract you have with your MMIS and what all is involved in that, and what would have to be done. From a regulatory and administrative point of view. But I would think inside a year certainly would be adequate time to put the structure together and the format together to see what that would look like. Certainly there are other third-party administrators out there that do this as a normal course of business. The Dental Association is interested in making sure that it has some role in overseeing it, so that the dentist, who is the deliverer of the services, isn't pushed to the outside, because the dentists are the ones who are on the front lines. I know at the last Arkansas Mission of Mercy that we had a couple of weekends ago here in Little Rock, they saw 2,006 patients, did $1.5 million worth of free dentistry. Well, that's done because the doctors are there, and over time they've gotten really good at using that field dentistry equipment, and they can make that happen. Same thing is true in their own office. They have their equipment, they're familiar with, their staff is familiar, they have their operations set up, so they're able to deliver services in an efficient manner that's commensurate with what they do on a daily basis. We kind of take that idea and enlarge it to say that we believe the dental program could be managed in the same way. There are other states who actually carve out the dental program largely for this same reason. It's a different animal from delivery of medical services, but I would think within a year, Senator.
What percentage of your membership would support going to third party?
I believe our leadership, our elected leadership, certainly does support that. If we were to ask the question of our membership, would you support a more efficient operation where you're able to see patients, treat them the way you need to, be reimbursed at a fair level, and be compensated correctly, I think it would be a very, very high percentage.
Okay, thank you. Thank you, Mr. Chair.
Okay, that's all we have on the list. I just want to ask one question in closing, and it kind of goes to what my co-chair asked here is, you said there's about $130 million right now currently in the program that we're spending on dental services through Medicaid?
Yes, sir.
But you're not going to give me a percent on what you think. And I noticed in the beginning paragraph there you said the program is dysfunctional.
Right.
So if it's dysfunctional, you ought to be able to cut at least 25%, save, right?
Well, I would love to do that. If that's the number, I will go back and work on that.
Well, I always hate it when someone takes your first offer, so maybe 40 or 50%.
We can shoot for that one too.
Would you? I guess what I think would be helpful, as our co-chair said, is we start looking at programs like that. What is a realistic savings that you could see through an efficient management of this program? That'd be helpful. Are there any other comments from members of the task force? Yeah, we don't have any idea. You may lose half your clientele, but members, I appreciate your diligence on sticking here till 4:30. I know we've been in and out of session and committee and sine die and everything else, but we also covered a lot of territory here today, and I think it was great information. I appreciate your input as far as our agenda items, and again, we've already got several items for next month. Mr. Tarpley, I appreciate you coming and sticking around till late in the day and the outstanding presentation. And again, members, this is in your notebook, and Mr. Price and the staff have done a great job of keeping this stuff together here for us. There's still a lot of 1332 stuff in your notebook if you want some reading material to take back. But unless somebody has anything else, Mr. Co-Chair, we will be adjourned until next month. Thank you all.